Ladies and gentlemen, good morning and welcome to the Demo Box 3. I hope you are all well and happy to be in Brussels. This is a very important session to understand what we are delivering and why we are delivering oxygen therapy in patients with acute hypoxemic respiratory failure. I'm very delighted to introduce Professor Martin Dres from the Paris Sorbonne University. He's certainly one of the most talented European researchers and clinicians, and his field is respiratory physiology. So this is why we are going to look at the delivery of high-flow nasal oxygen from this clinical perspective. My first question to you is, who is delivering on a regular basis high-flow nasal oxygen in patients with acute hypoxemic respiratory failure? Can you just raise the hand? Okay, so the vast majority of you, and now we are going to understand why. Martin, thank you.
Yes, good morning, everyone. Thank you, Elie, for the introduction. It's a pleasure for me. It's a privilege as well because I do this presentation with Elie, who has been a mentor for me. So thank you, Elie. Great pleasure for me. We show you our conflict of interest, and we start with this study. It's a simple study, actually. You know, it's in palliative care. So patient in a palliative condition, and the investigators, they just compare two strategies of oxygenation in the idea to relieve patient from their dyspnea. So you see that there were two different strategies: room air with 2 liters per minute, or oxygen 2 liters per minute. And there is no difference. Okay, so you have the same flow. In the green, you have oxygen. In red, you have only air. So it suggests that even if you add some oxygen to patient, even with a very low flow, you have no difference in the dyspnea in the patient. Another study here basically is the same, but what you can see is that the level of the flow, the amount is much higher, because here we are still looking at the dyspnea level in still palliative care. But you see that in the blue, you have a patient with conventional oxygen therapy with 8 liters per minute. So it's just a little bit higher than 2 liters per minute, but not a high flow, but it's oxygen. And here you really have high flow, 35 liters per minute, but with also high FiO2, 70%. And here you have a difference.
Martin, one question is, you say higher flow as compared to lower flow. What is the flow of a patient with hypoxemic respiratory failure? Because you need to nourish this flow as to keep a constant FiO2 that it has administered. So how do you estimate it on a clinical basis, and what would be the number?
So do you know in the audience what the flow of patients who are having an acute respiratory distress?
So we consider here that we are having 4 to 6 liters per minute of flow on breathing normally. What would be the case in a patient with acute hypoxemic respiratory failure? To how much would you estimate the flow? So you can have an idea on patients that we are winning on mechanical ventilation, and you see the expiratory tidal volumes, so you can estimate the minute flow for these patients. What would you estimate as numbers? Are you closer to 8 or closer to 35? Closer to 35. Martin?
Yeah, you're right. You're close to 35. So here, with this kind of strategy, with this kind of flow delivering, you reach much better the demand of the patient. And here we can probably suggest that we have more than a FiO2 effect, a real flow effect, because here we are probably goes over the demand of the patient, which explain why you have a decrease in dyspnea of the patient. So let's get back to some physiology, because the idea here is to discuss the effect of high flow and why high flow has some benefit in the clinical practice. So it's just an idea to present some physiological effects, and I'm sure that you know some of them very well. We will look at them in details, but it's a kind of sum up here with a CO2 washout, because this high flow allows to wash out the CO2. We will see that later. Maybe we can also discuss some lung recruitment, because we put some pressure in the lungs, so we may reopen some part of the lungs that are closed. Obviously, we may provide some oxygenation. It's the idea with a high FiO2. And at the end of the day, we may decrease the work of breathing of the patient, which we think that would be beneficial for them. So let's go into some of the physiological effect and some detail. This is a nice study by Tommaso Mori. It's quite, I don't know if it's old, but it's almost 10 years now. So here, the investigators, they use the esophageal pressure. You know, the esophageal pressure, it's the pressure inside the thorax that change when you take a deep breath. Okay? So it translates the pressure provided by the muscles. So this is why it is very interesting for us when we really want to assess the work that is done by the respiratory muscle. This is really probably the best way to evaluate the work done by the respiratory muscle.
About the esophageal pressure, maybe have you used it already? This is something that can be obtained with some ventilators, and it's also something that equals somewhere pleural pressure. So when Martin delivers information about esophageal pressure, you need to understand that for some of us, it's much more than experimental research. This is really how we should assess complex mechanical ventilation. So we are not into pleural pressure, we are into understanding how is the interaction between the patient and the ventilator. Can you tell us more about the swings, about the way you are looking at esophageal pressure, Martin?
Yes. So now, for instance, at the end of expiration, your pleural pressure, so your esophageal pressure is around 0. Okay, because you are not under invasive mechanical ventilation, you are not under positive pressure ventilation. So you are around 0, maybe a little bit positive, but between 0 and 1. And when you take a breath, you decrease the pressure inside the thorax. So the esophageal pressure will translate that and will indicate you the amount of the work that is done by the respiratory muscle, not only the diaphragm, but all. Okay, it's really a way to assess the work that is done by all the respiratory muscles, the diaphragm, and all the other muscles. So when you have this decreased, it just reflects this work of breathing. And here, what the investigator did is that they measure what you see, it's a delta pressure, so it's really the swing, okay, the change in esophageal pressure during a tidal breathing. And what they found is that comparing face mask, so up to 15 liters per minute, but not higher, of course, to high flow in yellow here, so up to 70 liters per minute, they showed that you decrease. You know, even it's all points represent an individual patient. So you see that for all the patients, you don't have always the same behavior, but the overall is that when you use high flow, you decrease the swing in esophageal pressure, suggesting that you decrease the work of breathing. So this is really a very important goal when you take care of patients with acute respiratory failure, because those patients have a huge work of breathing, And if you want to avoid intubation or worsening, you need to decrease the work of breathing, which is clearly something that you can do with high flow.
Martin, 2 points here. One is, do you say that it's the way to cure what we call respiratory distress? And if yes, my question to you is about the comparators in the literature. When we compare the use of high-flow nasal oxygen, some studies compare to conventional oxygen therapy, but some compare to non-invasive ventilation, whatever, pressure support, CPAP, etc. Would CPAP or pressure support bring the same effects on respiratory distress? And then from that, can we have an extension in the discussion about what would be the comparator for respiratory distress?
Sorry, I missed the question. Or the answer.
The question is, would we have the same effects using CPAP?
Oh yeah, for sure. Yes, we do have the same effect, but the problem is that if you apply positive pressure ventilation, there are some conflicting data, but it may also be deleterious for the lungs because you have injured lungs. So if you apply the pressure that is generated by the respiratory muscle plus the pressure that is generated by the ventilator, you may increase the stress, what we call the transpulmonary pressure, and it could be deleterious. I say it could be because there are some conflicting data. Maybe it depends on the severity of the patient, of the condition of the patient, of the post-surgery patient or medical patient. We don't really know, but it's a big question.
And it has clinical implication. If you look at a very nice study that was an observational study in patients with acute respiratory failure, there is a clear evidence that if you look at the subgroup of patients having less than 150 PF ratio, and if you apply non-invasive ventilation in this patient, there is an increased mortality. So the physiological concept is looking at the patients. And this is the translation. If you have a patient having a self-inflicted lung injury by having very high respiratory drive, but on top of that, as said by Martin, you are adding a positive pressure, so then you are generating strain on the patient and creating a kind of ventilator-induced lung injury. So this is why, yes, CPAP or pressure support, non-invasive ventilation would bring the same effects, but here we are in a system that doesn't add a substantial positive pressure, even though we are going to look at that in the next slides. There is a kind of lung aeration using high-flow nasal oxygen.
Yes. So this is exactly the perfect transition. You know the slide very well. So here, the same study, they measured, I won't go into the details regarding the way they did that, but they measured the lung volume here. And they also showed, as you can see, that when they used high-flow nasal oxygen, they could observe an improvement in the lung recruitment, so more aeration, and probably because of recruitment. And it seems that in contrast on the slide just before, where there was some, some patient who had not all the same behavior, here all the patients had the same behavior with an improvement in terms of lung aeration and in terms of increased lung volume.
And there are three sources for that. One is there is a very small study published in Italian journal showing that in patients with tracheostomy, when you put high-flow nasal oxygen, you generate close to 5 centimeters of oxygen, of water, of positive pressure. And there are now more data on using CT showing that using high-flow oxygen, you are also having the same proof of aeration in the lungs. So would you say that it is recruitment? Would we consider that this is part of the reason why there is a higher oxygenation in patients with high-flow nasal oxygen? I would say that for today, we keep that at the level of hypothesis, but there is an evidence for lung aeration. Please keep it interactive. Would you have any question, comment? Yes, please. Yeah, there are two mics.
Yeah, thank you. Michael Gazar from Leuven. Now that you're mentioning indeed that there might be a recruitment effect, increasing lung volume, a discussion we quite often have, as we use a lot of high-flow nasal cannulas, is if you have this kind of indirect effect that takes some time, in your experience or in your judgment, after stopping high-flow nasal cannula, should you wait a day before sending the patient up and seeing whether you lost the... I think not the same day at least. That's my point. I think stopping it in the morning and sending the patient out at noon, you will not know whether this reversed or not. But what is your judgment and experience on this?
No, it's a very good question. The question is regarding the winning of high-flow nasal oxygen. And what we know is there are other studies that are not in the slide deck here, but the lung volume that is recruited is dependent of the flow. And the higher the flow, the higher the recruitment. So I think that we should probably take care of the patient under high flow as we do for NIV in COPD patient, for instance. And usually we don't switch off NIV directly. We try to reduce progressively the pressure support and potentially PEEP sometimes if we have patients with very high levels. So I would do the same here, and in our clinical practice we do the same. We decrease the flow, and when we go to normal flow, let's say between 15 and 20, probably the patient does not need anymore this kind of technology and device. So we try to switch them to face mask and see how they tolerate.
Yeah, we keep the flow first and oxygen only after. Please.
Okay, no, just a point, Jean-Christophe Richard. I work with Air Liquide Medical System. It's a conflict of interest. Just regarding the previous slide or your comment about patient-safe inflicted lung injury. Correct me if I am wrong, but one of the main determinants of PCD is the transpulmonary pressure, which is the difference between airway pressure delivered by the system and the esophageal pressure. And as a result, this transpulmonary pressure that may generate some CD may be observed with or without positive pressure ventilation. So what you say about the additional value of high flow regarding CD is working only because with high flow you reduce the drive and you will reduce the esophageal pressure. So I think it's important to say, because you may obtain a reduction in esophageal pressure with CPAP or pressure support ventilation, and then also similarly results patients have infected lung injury.
Yeah, I agree, and I think that we should also consider CPAP on one side and NIV with two levels on the other side. Sure.
Just to make it clear, self-inflicted lung injury would be because patients, because of the respiratory distress and the severity, are going to generate a respiratory drive that would mimic a kind of 12 milliliter per kilo in the ARMA trial. You remember 6 versus 12, increased mortality in patients with 12 because it was too much. We would never ourselves give this kind of tidal volume in patients receiving mechanical ventilation. So it's self-inflicted because it's not medically decided, but still it has a translation into increased lung edema, and there are models for that. And there are also very nice evidence from the trials that those patients having high expiratory tidal volumes when they are receiving non-invasive mechanical ventilation are at higher risk of getting intubated. Please, Martin, let's go on. No question no comment? Please feel very free even to bring your experience.
Yeah. So this is a nice slide. I think it's very frequently showed in a conference to explain the effect on CO2 washout with this team that could get different images of the gas with CO2 in control and with so without high flow, and here with a high flow of 45 liters per minute. That shows that basically you completely remove the CO2 with this high level of flow. That's why it's an effect that is very interesting. for instance, in the COPD patient with acute exacerbation of COPD, because you're probably aware of the big studies that have been conducted in the setting of acute respiratory failure, the Florali study, for instance, but some others. And those studies were clearly focused on patient hypoxemic acute respiratory failure, but not the hypercapnic. And we have some studies going on as well, but not yet published. I mean, trials, clinical trials that probably will show some benefit also. I think this is what we do expect. And one of the effects could also be led by this physiological message here that with this high level of flow, we can obtain a CO2 washout.
Do you look at CO2? I know that you look at CO2 in patients with RDS, but this is another literature. But these are non-mechanically ventilated RDS. Do you look at CO2 in these patients?
No, not in our practice. We don't know.
I think it's a very nice. That brings for the oldest of us, you're too young, Martin, the effects of tracheal gas insufflation from the 85 evidence. I'm sorry, I'm reminding you your age. But this is a very nice evidence that we are actually bringing physiology to the bedside. This is why it's very important.
Yeah, I think there is a kind of gap for high flow here, because if we look at NIV, we had a lot of physiological studies in the 80s and the 90s by Laurent Brochard in Henri Mondor. And before going to clinical practice, we had a lot of physiological studies. And for high flow, it's exactly the inverse. We had these big studies, the Florali study, that showed the benefit of high flow. And then we are trying to understand with some physiological studies. And potentially, I think this is one of the reasons why we don't have yet some evidences to do that in hypercapnic respiratory failure, because we need some physiological data. So this is just a slide to go back to what we just discussed earlier on the very first slides to explain why the interest of high flow is exactly to overlap, you see, to overdrive the demand of the patient. Because if you have a patient with, let's say, 20 breaths per minute and a tidal volume of 500, so it reached something like 2.5 liters per minute of minute ventilation. So if you use a face mask, you see that you are below what the patient have in terms of minute ventilation. But if you use the high flow, you can be much higher, which potentially also explain the benefit of the device.
Very clear. You are able to deliver a constant FiO2. And there are pediatric data. I don't know if there are pediatricians in the room. As you know, in the UK, it has been very, very much used in the pediatric setting. And there are data showing that when you exceed patient's drive, you are really able to provide constant FiO2 and then able to better treat hypoxemia.
Yeah, because between that and that,
yeah,
the 2 liter are going to be air, room air. Okay, so you are going to dilute the FiO2. That's why you won't have the FiO2 that you think you are providing to the patient. So that's why it's important to be higher in order to maintain constant the FiO2 that you want for your patient.
And this is also why for patients on spontaneous breathing, guessing what is the real FiO2 that they receive is quite impossible. You can assume some equations, some considerations, you can put devices, but at the end of the day, it's an estimation, and you should not rely too much on that.
So we also wanted to show you some studies suggesting that maybe the high flow could also have a local effect, because we are using a device that goes directly to the nose, so it will stimulate the nasal cavity and potentially could also have some effect directly to the brain and to the respiratory drive. Because here you see that in the nose you have some termination of the olfactive bulb, but you also have some receptors that could be stimulated by this high flow, which could also interact with the brain and potentially alleviate the dyspnea and decrease the respiratory drive. And there are some studies in the literature showing that with nasal inspiration, you have this interaction and some projection from the olfactory bulb to some areas in the brain that could be affected by this different level of flow and provide some activity in some part of the brain, potentially that could fool the brain. And if the patient has a respiratory distress, and you can fool the brain, so just try to activate some part of the brain for the patient to forget that he has the respiratory distress, you may also have an effect on the respiratory drive and on the dyspnea.
Martin, does it work with air as much as with oxygen?
Yes, so the idea is that it's independent of the FiO2, of course. It's only a kind of
Flow effect.
flow effect, yes, mechano effect. So just to convince you, I wanted to discuss also and show these studies by a very famous group, Cristina Zelano, who has been working a lot on the nose, the nasal breathing, I would say. And there are very nice studies. Here you have a nasal breathing on the left and mouth breathing. So now, right now in the room, I'm looking at you and you're breathing through the nose, which is quite normal, right? You don't breathe with the mouth on. Maybe if you are sick, you've got a flu, but you know that when you breathe through the mouth, you don't feel well. When you got a flu, you don't feel well. So here, what they just showed is that when you breathe through the nose, you have a nice synchronization between the respiratory signal and the olfactive signal. This nice synchronization, perfect synchronization, is clearly showed here, whereas you don't have this synchronization when you breathe through the nose, which makes sense, right? Because you don't activate the olfactory bulb. But more than that, and really I was fascinated by this data, here you have breathing through the nose or breathing through the mouth. And here, of course, there was a nose clip to make sure that the subjects were not breathing through the nose. And what you can see, here you have the response delay, and the subjects were asking to do some task, cognitive task. And the investigators, they measured the response to the task when the subjects were breathing through the nose or were breathing through the mouth. And what is really clear here is that the performance of the subjects were much better when they were breathing through the nose, right? Performance, but also accuracy. So basically the tasks were a memory task, just to read a text and be able to restore to after a few minutes to spell some letters or some values. And you see that when you breathe through the nose, you are better and more accurate.
Martin, can we translate this in clinical practice? Because when we look at our patients, it's rare that they have a clip somewhere. So this is one of the strengths from delivering high flow through the nose. So when we see a patient, can we make the decision to deliver high flow from the nose only based on that, even if the patient is otherwise in a good respiratory status?
But you mean through the nose and not because usually we use nasal sprongs or
we use nasal
cannula.
Or cannula.
Okay.
But if you have a patient, for example, receiving 12 liters of oxygen, you would convert the patient to high flow nasal oxygen. But if you have a patient having 4 liters of oxygen, do we have now here arguments to deliver this through the nose based on this data?
So those data are in LC, right?
Yeah, of course.
And the problem is that we said that earlier, but when you have a respiratory distress, you are not normal, so you breathe with the mouth that is open. So I'm not sure that we could obtain the same efficacy in a patient with the mouth open, and this is something that we perfectly know in patients with high flow. It's better when they can close the mouth because you have the PEEP effect that we just discussed before. So potentially this is something that could be interesting. There is a question.
Thanks, Annika Rentam-Blaser from Lucerne, Switzerland. I tried high flow during just to feel how it is in our team. And 40 liters, it's almost impossible to keep the mouth closed if I don't have any dyspnea. It's just so personal.
Because you low respiratory rate.
Yeah.
Yeah.
No, it's very interesting point, but I think that when high flow is well seated with a very high flow, sufficient high flow, even if you open the mouth, it limits the PEEP effect. But regarding the FiO2, as discussed before, and probably regarding the effect, the neurological effect on the nose, is still working. So closing the mouth with high flow is important for keeping PEEP at the level, but not for FiO2, as with for CO2, is the same. So it's interesting. And just a point, I met Martin 6 months ago telling me this story, wonderful story, and I am a rock climber, and I started to use my nose and not open my breath by my mouth open. And I improve significantly my precision and my performance.
It's not doping.
It's really fantastic work.
So Jean-Christophe, you mentioned one of the others paper from Tommaso Mori. So the effects of high flow oxygen have been evaluated using standard settings, but also with increased flow. And you don't have to have 40 liters for everyone. For example, CO2 clearance and even the reduction in work of breathing is significant after 20 liters. So I think that we just need to understand what we are looking for. If you can compensate the respiratory drive, this is your target. Once you are feeding the patients, you can consider that you have most of the physiological strength of high flow nasal oxygen. Not everyone should have 50, 60, or even 70 liters per minute. This is very important.
Yeah, it's important. And I think potentially sometimes we forget to interact with the patient. Absolutely. Exactly for what you said, to make sure that what we are applying is not too high. And maybe just discussing with the patient and trying to titrate could improve the interaction.
Well, now we have a question for you. We discuss with the patient. What would be the important patient-reported outcomes on which you would make decision, increase, decrease, or maybe change the setting of your high flow? There are some that have been assessed in the literature and some that you have maybe yourself as an experience.
Temperature. Reported increase like heating, overheating. Or
estimate it, but it's very, merci Martin, it's very difficult to really assess the respiratory drive. So if you want to know whether you have really compensated the stress, what would be the question you are asking to the patients? The nurses do that very well for us, but we are also having some questions ourselves. What would you ask, for example? Naturally, you would ask the patient whether she or he feel better, breathe better. What else? Any suggestion? So there are three things that have really been assessed in the literature and are interesting because they translate into the understanding on the number of patients that are going to deteriorate. Remember, during the COVID-19 pandemic, we were not taking all the patients to the ICU because of the shortage of beds. So one of the things that works very well is comfort. So comfort can be assessed and is very reliable as far as you are not giving your own on the. You just need to understand how is the patient comfort. This is the first one. The other one is respiratory rate. There are a number of patients, the papers showing that for patients remaining tachypneic under non-invasive ventilation, like under high flow oxygen, the likelihood of getting intubated is very high. Because sometimes, you are in a system that makes that you cannot avoid every intubation, and maybe not all the intubation should be avoided. What would be the other patient-reported outcomes that you would rely on? This is for Martin. Dyspnea.
I know the answer.
Dyspnea. So can you tell us more about dyspnea in these patients when they receive high-flow nasal oxygen?
Yeah, so dyspnea, it's something that we should take care because it's quite easy to ask the patient, and actually we do that for the pain. Okay, everyone knows that we should evaluate, assess pain in patient, but we sometimes forget to assess dyspnea. And actually, if we try to use a treatment such high flow to relieve our patient, we should ask them if the dyspnea decrease. But if you want to do that, you need some scale, you need some rating to make sure that you can follow up the patient. So in patients who are under high flow, usually they are communicative. So it's not a patient who is intubated in whom it's much more complicated to have a good interaction and a good understanding of what they would like to say. But if the patient is communicative, you can just ask them about the dyspnea and give them some rating, numerical rating scale, for instance, from 0 to 10, the same as for the pain, to make sure that when you set, for instance, the flow, that the dyspnea decrease and follow up them until the treatment is okay.
Martin, we have 3 more minutes. I have one question for you. So if we look at the literature, you can see Florally, you can see other papers on high-flow nasal oxygen in acute hypoxemic respiratory failure. Clearly, there is the evidence that we reduce intubation. So you listed a number of physiological strengths. What is for you, the expert, the one or the numbers that are really responsible for this reduction in the number of patients getting intubated?
I think it's, to my opinion, it's potentially the reduction of work of breathing, because work of breathing is metabolic. You have the respiratory muscle function. So if you have a decrease of work of breathing, you probably also have a decrease in the cardiac output. That's why I think overall it may explain why it is associated with a decrease of the rate of the risk of intubation, even though it's not associated with a decrease in mortality, but not all studies actually. But I think yes, because improving oxygenation, decreasing improving CO2 washout, improving lung recruitment, at the end of the day, may lead to the decrease of the work of breathing. So that's why I think this is really the main effect.
Yeah, and by the way, when we look at the reason why patients are intubated, it's mostly about exhaustion.
Yes. Yeah.
And that takes me to my maybe last question, because we have only 1 more minute, 1 and 20 seconds. Prone positioning in awake patients receiving high flow. So are you combining additional physiological effects, and do you consider that it's something that we are going towards it in the close future? Because there are evidence, but very little implementation. So what's your view on that?
Yeah, I think it's a good point, and for me it's a good way to say that more than ever we should personalize, individualize the treatment to our patient, because this is true that there are some data, even though not all studies are showing exactly the same effect. But I think, again, because those patients are not intubated, they are communicative, and we can interact with them, discuss with them, and titrate the flow, ask them if they are more comfortable in prone positioning. I think it's a good way to personalize our treatment and to improve treatment, and I hope the outcome at the end of the day. But I mean, not all the patients will react the same way. So I think here it's a good field for that, to personalize and individualize the treatment.
So if we want to summarize, talk to your patients, look at them, breathe from the nose, and personalize the treatment of hypoxemic respiratory failure. Thank you very much, and have a wonderful session.
Thanks.